How is everything?
Yeah, thank you, Sami. You're very kind. Hi, everyone. My name is Mario. I also recently graduated, actually, like 3 days ago. So yeah, just transitioning to a different stage of my career, and I'm from Lima, Peru, and I have a very interesting case to present to you all today. So hopefully you'll enjoy it.
Awesome. I'm just very glad to be discussing with Sami today, and also excited to discuss a case with Mario. I just had a wonderful hour of power just listening on a case we had here of Evans syndrome. So I remember there was 2 cases, I think, of Evans syndrome recently. So I'm all pumped up and ready for Mario's case. So should we start?
So yeah, let's start. So this is a case of a 44-year-old female that presented with a 10-month history of progressive dysphagia, diarrhea, and weight loss. Do you want me to stop there, or should I proceed with the HPI?
I think we can stop for a second. That's absolutely incredible chief complaint that we can sort of dissect apart. But what's going through your mind, Sami?
Yeah, very interesting. Not something I think too often about. So we have a middle-aged female with a chronic time course of progressive dysphagia, diarrhea, and weight loss. So definitely the GI system seems involved, right? Maybe I can share my first thoughts and then pass it over to Ravi to add what I'm missing. So dysphagia, I'm always thinking about, is there like an obstruction? I always remember Ravi saying, is there like a tunnel that, like, imagining the esophagus being a tunnel and either something is obstructing it, either from the inside or the outside. For example, inside, you can have esophageal cancer, you can have webs, stuff like that. Or from the outside, you can have a massive heart, for example, or you can have a mediastinal process. Or you can have a problem with motility, maybe, for example, scleroderma. Achalasia, for example, could also fit with the time course, more of like a chronic process in comparison to like an esophageal cancer, where it's maybe more of an acute onset of the dysphagia. Diarrhea, yeah, very broad differential. First, we have to really, I don't know, like clarify, is it really diarrhea? Is it stool incontinence? Are there any meds involved? The first pass will be infectious, but if it's like really 10 months going on, then we definitely have to get an HIV status, check the immune status of the patient, check for secretory processes, evaluate for fever, night sweats, and signs of inflammatory diarrhea. Is there any blood? How often does it occur? Is there tenesm? Are there signs of malabsorption? Definitely. Also, you can ask about nocturnal symptoms. This maybe pushes us more towards like an inflammatory process in comparison to like celiac disease or osmotic diarrhea or lactose intolerance that happens more with like ingestion of food. And the weight loss, yeah, I don't know, it, as Ravi always says, it just puts more pathology to this whole problem. You know, we have dysphagia, we have diarrhea, 2 causes of weight loss. We definitely want to know how much, how fast, and what are other accompanying symptoms. Ravi, what do you think?
Absolutely incredible introduction to this complaint. This does make for a very interesting complaint. I just can't imagine the amount of issues that this patient is having with having issues of both sides of the GI tract. So I'm trying to connect, like you mentioned, it's early on in the process, but I think we can start with dysphagia, like you nicely delineated. Is it esophageal, starting with the food bolus and so on, or is it maybe lower down in the GI tract? I'm not quite sure where to really concentrate at this point, but I think we'll go into the next aliquot and see what else unfolds. Back to you, Mario.
Okay, yeah, great discussion. So I'm gonna proceed with the HPI. So as we said, 10 months before admission, the patient refers, she presented some intermittent watery diarrhea without any mucus or blood in the stools, around 3 to 4 episodes per day. And these episodes were associated with subjective fevers and night sweats. She said that the symptoms persisted. She received some natural treatment. She referred to as banana water. I don't think we ever knew what she meant with that. But the symptoms, as we said, persisted. And 6 months later, so 4 months before admission, she developed, besides the diarrhea, dysphagia. It was initially predominantly to solids. The dysphagia got worse, and she actually had to start blending her foods to be able to swallow them. So a very severe dysphagia to solids. And at this point, she had lost around 20 kilos in this 6 month period. She went to an outside hospital in the town where she lived, and they performed an upper endoscopy, which they only reported she was diagnosed with Helicobacter pylori. She didn't even receive treatment, and she was lost to follow up from that outside hospital. This was around 6 to 7 months into her into her disease, into her illness course. Because of the non-improvement of her symptoms, she came to Lima, which is the capital of Peru, to our hospital, where she was hospitalized for further workup. And that's HPI.
I think I'll just sort of comment here. So as we have some more information, what's probably unfolding here, it started initially with this diarrhea. So maybe we need to dig deep into the diarrhea. And then with the accompanying fevers and night sweats, now that I can't help but think about possibly infectious inflammatory disorders. I think the weight loss is secondary to the GI process, not possibly due to inflammation, although this could be a combined process traveling together. And then this developed with dysphagia. So the dysphagia may be a progression of what's causing this. This is a condition that's actually involving the whole gastroenterological tract. So have to start thinking, is it a primary GI process, or is this something like a systemic process plus inflammation? So digging deep into maybe possibly some of the autoimmune phenomena. And then also, I think what maybe the order of the day is definitely doing some imaging studies and further GI scope. So an upper endoscopy was done, and I assume it was normal. So there could be some functional issue we have to start looking at. If there's not a morphological issue, maybe there's a functional disorder of the upper GI tract. And when we think about muscle, mucosa, what consists of the anatomy of the GI tract. So various layers could be mucosa, submucosa, the mucosa-associated lymphatic tissue, and then the muscle. If I remember correctly, like the upper, maybe somebody has to correct me, but upper 2/3 is skeletal, the lower is third is smooth muscle. And we recently had a 30-minute VMR last week with Jack, who went through very nicely a case of achalasia. So something to think about, but I'm not sort of getting the typical presentation of achalasia with this patient. The diarrhea does definitely worry me. So that's something we may have to sort of dig into and try and connect the two processes. What do you think, Sammy, at this point?
Yeah, I'm totally with you. I think that just further amplifies our suspicion that this patient is seemingly inflamed. The H. pylori history is interesting, and also that it's not that it didn't get treated. Then you can think of complications of H. pylori, gastric cancer, carcinoid syndrome, stuff like that. Another thing I wanted to mention, HIV could also present with like inflammatory diarrhea and also dysphagia if you get Candida esophagitis. He had an EGD that seemingly was normal except for the H. pylori being positive. Yeah, and I'm also like a little bit into ID. And one thing that popped up for me when you hear dysphagia in a patient from South America, you should always think about Chagas disease. I know that's not like the most typical manifestation with diarrhea, but just to throw it in there, in the end stage, it can present with dilated esophagus, mimicking achalasia, also like termed pseudoachalasia. It can manifest in the GI tract, but maybe more like of a constipation picture, I think, and also can have cardiac involvement. But I don't think that it is at play here, but was just wanted to throw that in. But yeah, I'm definitely interested in the immune status, and yeah, Maria's cases are always so interesting.
Yeah, Mario, I guess we can go with the next aliquot.
Yeah, those are also great points and great questions that I will try to answer. So in terms of past medical history, the patient had asthma diagnosed a while back, and the patient also had an episode, and she had dengue in 2 years before. Besides that, no other diseases or allergies. She didn't take any medications, no previous hospitalizations. In terms of sexual history, she had two sexual partners during her lifetime with no protection used. She worked as a kindergarten teacher, denied any alcohol or recreational drug use, no tobacco, and the only recent travel was when she came to Lima. She lived in the middle of the, like in Peru, you can separate the highlands into northern, central, and southern parts. She was on the northern part of the highlands. So that's, and no significant family history. Do you want me to stop there, or should I continue with the vitals and exam on admission?
I think we can involve the exam as well. Then I'll have Sammy take a stab at that. Okay,
so on the vitals, heart rate was 73, so no tachycardia or bradycardia. Respiratory rate was 16. Patient was afebrile with a temperature of 36.8 Celsius. Blood pressure was 130/80 and was setting 99% on room air. She looked on the physical exam, she had a regular general condition, regular hydration. She did look malnourished. On the skin and mucosal exams, she had dry skin. Onychomycosis was noted on all of the nails of her toes. She did have oral thrush, and she also used a prosthetic dentature. But so dry skin, onychomycosis on all of her fingernails on the nails of her toes, oral thrush, and she used a prosthetic dentature. As I said, she looked malnourished. She had two palpable cervical lymph nodes of 0.5 centimeters per times 0.5 centimeters on her anterior cervical chain. Only two. They were non-tender. They were mobile. And on the abdominal exam, hepatomegaly was noted. The rest of the exam was normal. So cardiovascular, pulmonary, and neurological exam were normal.
Okay, wow, it gets even more intriguing. Thank you so much for this aliquot. Yeah, for the southwest corner, I don't have too much to make out of that, except that we have a heightened suspicion for an STD that because she didn't use protection, so an HIV test, we would definitely get that. Otherwise, I was thinking asthma. Whenever I hear asthma, and especially if it's like late onset and someone lives like in an endemic area, you should think about strongyloiditis that can manifest with chronic GI symptoms, weight loss, diarrhea, eosinophilia, and asthmatic symptoms. So maybe if the suspicion heightens, we could check for that, stool over and parasites and serology. Yeah, but apart from that, I can't make too much out of it. The dengue 2 years ago, I guess, is not too uncommon in this region of the world. yeah, but I wouldn't make too much out of it right now. Otherwise, the vitals are seemingly stable. There's no fever, which doesn't really eliminate the possibility of inflammation. Reza always says fever is like the most specific finding of inflammation, but it's not the most sensitive. So just because we don't see a fever, it doesn't mean there's no inflammation. We still have this suggestive history and findings. So yeah, I wouldn't dissuade from it. Otherwise, the oil thrush is very suspicious for like an immunocompromised state. The most common cause would be like local immunocompromised, for example, if patients have eosinophilic esophagitis or atopic diseases and take oral budesonide, for example, and then don't rinse their mouth, and then they can get oral thrush. But in this setting, I would be deeply concerned about a more systemic immunocompromising condition, for example, HIV. And if she has thrush in her mouth, what maybe she's also having it in her esophagus, for example. The cervical lymph nodes, I don't know, only 0.5 centimeters. If I touch my neck right now, I think I'm having, they are like 1 centimeter each. So yeah, maybe you could account that as local lymphadenopathy. I got very, since I started practicing like on my own, I got very, careful with like noticing every lymph node, because that requires further workup. But in this setting, I would definitely check the axilla, check the inguinal regions, and maybe check deeper structures with cross-sectional imaging if there's like generalized lymphadenopathy. Yeah, otherwise the hepatomegaly, yeah, it's interesting. I think we should definitely get more, maybe get an ultrasound or a CT to check if also the spleen is involved. This would like open more possibilities. But when I think about hepatomegaly, I mostly think about any sort of inflammation, hepatitis, either it's autoimmune or infectious. Is the like swelling of the liver, for example, because there's impaired venous drainage, for example, in heart failure, or is the like some sort of molecule infiltrating it for like in like storage diseases, stuff like that. Yeah, stuff like that. Those would be my preliminary thoughts. And yeah, Mike, to you, Ravi.
Oh, incredible journey through the landscape of this case. It's just impressive how you've brought everything together and try to generate some hypothesis. And I think many of them are definitely in the running, but which one to really expend your cognitive energy on, I am not sure. But definitely as we have more unfolding features of this case, we now see a question early on was, is this something just targeting the GI tract primarily, or is this something systemic? And here we clearly see there's many other systems involved here. We have signature in the liver, we have signature lymph nodes, there's night sweats. So immediately system one thinking, I was starting to think about lymphoma. What if there is lymphoma causing something like this? Then again, that's why I highlighted the gut associated lymphatic tissue. So that could always harbor lymphomatous diseases. The other thing is what kind of infections? The other thought that we had inflammation, we had infections, we had autoimmune phenomena as well. So the number of different infections is just so many. The landscape, if you run through, people are mentioning all sorts of viruses. If you run through, I'm not sure in that part of Peru what kind of infections, if this patient was maybe exposed to cows or unpasteurized milk, you have to start thinking about brucellosis. Can this, so I have to start looking through which one of these diseases can actually have features with the gut as well as the lymph nodes. So brucellosis could be something there. Then you have to start thinking of the Bartonella bacterial diseases. A couple of people mentioned in the chat the viruses, so running the whole gamut of viruses, CMV, HSV, HIV, definitely you have to pay respect to those. And then starting to look through maybe somebody had also mentioned the NTM and TB, definitely you also have to consider in something like this, although GI symptoms less likely unless it's systemic NTM. Somebody also brought up if this patient is immunocompromised or not. So with the thrush, not necessarily unless the patient has esophageal candidiasis that could explain some of the dysphagia, and it's very, very painful as well. And you can get all sorts of progression to inflammation and scarring, and it can be a devastating condition. But just having oral candidiasis, could this be maybe a harbinger of maybe, or secondary to maybe something like a hypogammaglobulinemia or CVID, one of the immunocompromised states, not necessarily acquired like HIV. Other conditions where you may get, especially cervical lymphadenopathy, if the patient had any encounter with other animals like rabbits, so tularemia comes into play, then syphilis, and then we talked about viral hepatitis. And which one of those have diarrhea? I'm kind of forgetting, but I think I would put all of the thoughts on the table and start sort of testing for those. So I'm sure Mario probably ran a whole spectrum of tests to rule out many of these different things. If we look at autoimmune phenomena, we had a case of Sjögren's. If this patient had particularly some Zika symptoms, maybe we can start thinking of like Sjögren's. Dermatomyositis, a couple of weeks ago, we had a case of dermatomyositis, and you can get GI involvement due to skeletal muscle. If you're thinking about dermatomyositis, polymyositis, it does affect the skeletal muscle. And guess what we have in the GI tract? We also have some skeletal muscle in the upper portion of the esophagus as well. And then pure muscle disorders, I think in the cricopharyngeal muscle is involved in inclusion body myositis, but peripheral muscle involvement, we don't have that finding here. So I think if we can sort of consider the landscape of autoimmune, but heavy on infections and also on the lymphomas at this point. So testing in these areas, I think, will pay dividends in trying to narrow down what's causing this. So we've generated a plethora of hypotheses. Now we need to refine further, and I think we'll do that through diagnostic testing. So on to the labs now, Mario.
Yeah, great thoughts again. I'm gonna go with so there's a bunch of auxiliary exams we performed, including laboratory exams, imaging, and further workup. So on admission, the patient was found to have a hemoglobin of 6.5, a leukocyte count of 4.2, with an absolute count of lymphocytes of 572. So the patient was lymphopenic. Normal platelets with a count of 246,000. Besides that, sodium was 138, potassium 3.3, chloride 103. Total protein was 5.9, and albumin was 2. Total bilirubin 0.4, and ALT 18 is AST 29. We also some serologies were performed. Total protein usage was 5.9, and albumin was 2. So we performed some serologies on admission. VDRL, RPR were non-reactive. Hepatitis surface antigen was non-reactive. And ELISA for HIV was positive, and that was confirmed with a Western blot. That's what is done usually in Peru. So from the serologies, she was HIV positive. Stool, and parasite and stool exam was performed. There was no blood, no mucus, no yeasts, no parasites, and the cultures came back negative. I can repeat any of the labs if you want. So stool exams were all negative.
I think I'll start here. We have the whole hour. Let's do this. I think actually it's a great idea to maybe make breakout rooms and have people discuss just for fun. So we're at 1:30 and we're pretty advanced in the case. I think we can make room for discussion and use up the whole hour. So I'm going to assign people randomly to breakout rooms. So go in there and discuss amongst yourselves. And then what I'll have is each person from each, one person from each room kind of give us a summary of what you're thinking to help us in trying to figure out what's going on with this case. So hold on a second. Okay. All right, here we go. Awesome. Welcome back, everybody. That was fun. And I kind of hopped between different rooms, and it was great to hear a lot of different people that usually I don't get to hear from. So that really does encourage discussion. Do you want to start with Yusuf, your room, who was going to maybe share a few points? So what did you think about this case so far?
Yes, I can do it. So in our room, we discussed with the background of HIV, the likelihood that this is infectious is higher in likelihood, and the second highest thing in likelihood would be malignancy for us. Under infectious, we considered infiltrative disease, we considered TB and MAC, but we found interesting that the alk-phos was not that elevated, for example, for MAC. We considered the viral etiologies. We thought about CMV, which causes esophageal disease and can cause colitis. We thought colitis might be more acute rather than subacute. Other thing we discussed was if the iron deficiency is causing Plummer-Vinson, although we're wondering why the EGD did not show any webs. And these were our general thoughts.
I absolutely love those thoughts. Yeah. I guess Deborah, your room. Did somebody want to just chime in on a few things that you may have discussed?
Yeah, we have some great thoughts from Yushitash. I'm sorry if I pronounce your name wrong. If you want to share with us what you were saying in our room.
Hi, can you hear me?
Absolutely.
Thank you. Yeah, we discussed something related to like what could be the infectious cause of dysphagia and diarrhea, given that the patient has like the HIV test came back positive. Even though, like Yusuf just mentioned, there is a there are something that we were not able to like have a clear thought on, like whether the things related to like anemia and Plummer-Vinson syndrome and things like that. But we were mostly thinking about the opportunistic infection that could definitely cause like dysphagia and diarrhea, both like cytomegalovirus and Candida. But again, we will need to have like a CD4 count just to delineate the differential properly. And like differential, the CD4 count could like guide which infection is like more likely and which is not.
Yeah, that's a wonderful thought. Yeah, maybe we have two conditions that are simultaneously occurring. So this HIV, like you mentioned, with the Candida in the upper part, and then a HIV-associated diarrhea in the lower part causing these problems. So I absolutely love that idea. That's wonderful. And I think Leah's group, somebody wanted to unmute and maybe discuss a bit. What were you thinking?
Yeah, we can. So we talked a bit about also infections, and that whether HIV could explain all of our symptoms for now, or if there's more to be explained. So we definitely should make sure, just because HIV predisposes to so many other things, to not miss anything that is there additionally. But then we were also wondering why the liver labs were so normal with the hepatomegaly. So that will be interesting to kind of discover. And so yeah, so great thoughts also from Mohammed to think, okay, we should test for further STDs, for example, and also think about CMV and other viral infections. And our final point was that what would we do next? Maybe get more imaging also to help us with the diagnosis.
Absolutely love that as well. Great points there. I'm definitely going to include that in my analysis of this case. And Was there any other group that I'm forgetting? There was one more group. I'm not sure if.
Yeah, our group.
Oh, okay.
Shreyas, do you want to unmute and share your thoughts? You had amazing points.
Sure. Hi, everybody. So we were thinking almost on the similar lines. We were thinking it definitely looks like an infectious picture at this point of time, and infectious causes of dysphagia could include the esophagitis bugs like Candida, CMV, TB, HSV, and not to rule out we even need to rule out the immune causes like scleroderma. And like we were discussing in our group that while we were thinking of opportunistic infections like MAC and the rest of the ones which I just mentioned, HIV infection in and of itself in the form of acute retroviral syndrome could explain a lot of these symptoms in the form of diarrhea, weight loss, generalized lymphadenopathy. So I think just acute HIV infection in and of itself should also be thought about. And apart from that, thinking of diarrhea from another standpoint, like inflammatory, like IBD, IBS, small intestinal bacterial overgrowth. So these are some of the general thoughts which we had in our group. And we also thought of MAC infection, and we thought about how we can further go about to diagnose the MAC infection through the ZN staining. And so those are some of the thoughts which we had in our group.
Incredible. I think it makes my job easier. So encompassing everything, all those points, actually stellar teaching points from all of you. And thank you, Shreyas, for chiming in. Any other rooms that I may have overlooked? Anybody want to mention anything else that we should include in our differential? Yeah, what I would mention is now we're having to look at this case through the lens of HIV and then start discussing and considering all the HIV-associated complications or what kind of things you actually named a large number of different things. And going back to our initial hypothesis we generated, we thought about infections, and I think that's highly probable at this point. And we have enough of a probabilistic threshold to initiate diagnostic testing for all the different multitude of pathogens which can cause diarrhea in the HIV population. So anything from Cryptosporidium, Microsporidium, all the parasites, Giardia, Entamoeba, also Isospora belli. These can usually target patients with HIV, as well as the garden variety viral illnesses that can cause diarrhea in this patient population. And then also lymphomas as well. And then a number of the autoimmune conditions that people had mentioned. So I'm kind of interested. I mean, Kaposi's, somebody had mentioned getting the viral load and CD4 count to see how immunocompromised this patient is. So is it early in their condition where they are immunocompetent, or are they immunocompromised? And this could open the door to things like Kaposi's sarcoma, which can affect the GI tract as well, lymphoma, as we talked about, HIV, enteropathy. HIV can also affect the pancreas as well. We had a case of chronic pancreatitis recently where you will have diarrhea, although we're kind of missing the abdominal pain or the signature of abdominal pain. So a few things there, and I'll swing it to Sami to see if there's anything else before we go on to the next aliquot by Mario.
That was amazing. I just wanted to highlight two things in the labs. First, hemoglobin of 6.5. Well, you could see that and could say, yeah, she is inflamed. That's all due to anemia of chronic disease. If you have anemia of chronic disease, the hemoglobin usually doesn't go below 8 or 9. When the hemoglobin is 6.5, you have to exclude other things, for example, iron deficiency anemia, and we should definitely get an iron panel. That was my first point. And the other point was, you see this low albumin, which can have a multitude of causes, chronic disease, protein losing enteropathy, maybe in this scenario could also have liver cirrhosis and nephrotic syndrome, much more unlikely in this case. But you see that the total protein is 5.9 and the albumin is 2, and you can calculate a gamma gap. That's like the total protein minus the albumin, and here it's 5.9 minus 2 is 3.9, and the cutoff is like 4, and it's like approaching 4. And whenever you see that, you should say there's an imbalance, there's too much immunoglobulins in the blood. Normally there's 60% albumin in the blood of the proteins, and when you have 4 grams of other protein than albumin, you should think about hypergammaglobulinemia. Either it's monoclonal or polyclonal. And whenever you see in this scenario polyclonal gammopathy, you have to think of HIV, which we also saw in this case. Yeah, Mario, back to you.
Well, I'm very, very impressed, honestly. This is great discussion. And I think you're all going in the right direction. So I have one more aliquot and, well, two. The second one will reveal the diagnosis. So at this point, the patient was started on oral fluconazole for oral thrush, and a week passed and the patient still had very severe dysphagia. Surprisingly, the diarrhea almost resolved during this week of hospitalization, but as I mentioned, the dysphagia really persisted. So it was decided to perform a second upper endoscopy. Before that, I want to add that an ultrasound and an abdominal ultrasound was performed. There were no focal lesions. There was moderate hepatic steatosis was the only thing was reported on the abdominal ultrasound. So as I mentioned, a second upper endoscopy was performed, and in this case, the GI team described 7 ulcers with in the esophagus with a tendency to confluence, and the ulcer had a longitudinal aspect with raised edges from around 15 to 25 centimeters into the esophagus. And biopsy was performed. Do you want me to proceed with the biopsy or with the results of the histopathology, or should I stop in the endoscopy?
What do you think, Sammy? I think we generated a lot of possible thoughts. Anything comes to mind with this finding? Ulcers, what could cause ulcers?
Yeah, a lot of things, but in this setting, I would be most concerned for CMV. HSV could also be a cause. I know you can somehow differentiate them macroscopically. I forgot how to, but this would be my main diagnosis. And also, if we have it in the esophagus, why not in the colon? And colonic colitis due to CMV is also notorious for causing diarrhea. So yeah, we should definitely also get like colonoscopy and check the tissue for CMV. Ravi, what do you think?
Yeah, absolutely. I think also you did a wonderful or spectacular job of deciphering the labs and awesome teaching of the gamma gap there. So vital for a lot of learners there. And just want to also hone in on this lymphopenia. I don't know if it's due to the HIV, but this can be a hallmark of an acute viral illness. So you just named a couple of very important viral illnesses, which could be the cause of these findings. And then CMV does have also a signature in the liver, although we're not getting any elevated liver enzymes. But I'm just wondering, this fatty liver may, if it is caused by CMV in this case. But I absolutely agree. Yeah, those are great thoughts. Let's see what Mario has in store for us.
So yeah, with the EGD findings, the highest suspicion, as has been mentioned, was CMV esophagitis. Unfortunately, in our hospital, actually in all of the national supported hospitals in Peru, the viral load and the CD4 count, you have to send out tests performed by the government, and they can actually take up to 1 month to come back. So we didn't have the results at this moment. The patient was started on ganciclovir, but a couple of days later, we had the biopsy report, the biopsy results, which described an ulcerated. I'm gonna paste this on the chat because it's somewhat large, but the esophageal mucosa was described as having being ulcerated with a moderately to severe chronic inflammation, with moderate activity, some intermediate sized atypical lymphocytes without mitotic figures, and some cells with ejected nuclei and undefined nature could be seen. And stain was performed. PAS stain was performed for in the biopsy, and it came back positive. So it was PAS positive.
Ravi, you want to tackle that?
I am not too familiar with can't recall we did go over this before, but PS positive. Somebody mentioned, somebody's mentioning in the chat Whipple disease. So I'm kind of flabbergasted if it is Whipple disease, but Whipple disease usually have signature neuro in the brain and the joints. So it's kind of odd. Abraham's mentioning PS 2 weeks ago. So I guess we did dissect PS staining at that point. Anything else come to mind, Sammy?
Yeah, honestly, not too much. I also remember that VMR, and I also remember that we even talked about, I think, I don't know who it was, but someone also explained what it means and what do you see, but I also didn't remember it because it seems so complicated to me. It will haunt us, I guess. Yeah, PAS stain positive. I also always associate that with Whipple's disease, but that mostly manifests in the duodenum, not in the esophagus. Otherwise, yeah, I would definitely check what does it stain and what can we see with it. Otherwise, I can't say too much about it.
All right, Mario, all yours. Take us home.
So yeah, this was a very difficult case, honestly, because we were the same. We were thinking the same about CMV, HSV, especially in a patient that has oral thrush. You could usually treat empirically with fluconazole and see the dysphagia, or usually they have odinophagia. In this case, it was only dysphagia, and usually resolves. But this was not the case. As Hassan mentioned, PAS stain can stain bacteria. It can stain other microorganisms, and one of the microorganisms that can stain positive is one of the endemic fungi. Especially, you can get, as Hassan mentioned, Cryptococcus is in the differential, but also histoplasma. And I would love to be able to show you the biopsy, but the morphology was compatible with histoplasma capsulatum. So patient was started on itraconazole, and the patient improved. So the final diagnosis was esophageal histoplasmosis. Also, patient had HIV. New recent diagnosis: HIV without antiretroviral therapy and oral thrush. And yeah, patient was started on itraconazole and started to improve slowly, but started to improve. So I wanted to present this case because it's honestly one of the only case I've seen, and a lot of the ID specialists in our ID center was also the first time we had seen isolated esophageal histoplasmosis. They actually performed a bone marrow culture, and it came back negative. So as far as we were able to work up the case, it was an isolated esophageal histoplasmosis.
Wow, incredible case, Mario. Like histo without any signature in the lung. So the extra lung manifestations, this is one of them. And I've never seen this before. Definitely, I'm now thinking back we were considering HIV causes of diarrhea. And in the fungal category, guess what's number one? Actually, histoplasmosis. But I didn't have a huge suspicion for that. And this just kind of shows how humbling a case like this can be. And I just appreciate all the amazing thoughts from everybody in the chat and also in the group discussions. I was right there with everybody generating a huge list of hypotheses. And it was just very difficult, I guess, with each test. We were whittling it down and then just kind of stymied by this PAS positive staining. And it still generated a lot of different thoughts, but definitely, Mario once again has given me homework for tonight, so I appreciate that, Mario. Stellar case, absolutely fantastic. Thank you for preparing and presenting it. Sammy, any reflections?
Yeah, completely humbling, but it just goes to show you that with HIV, you can always get surprised. And I didn't think of histoplasmosis for 1 second in this case, although we could have, maybe if we would have had pulmonary imaging and we would have seen some findings there, then maybe we would have thought more about it. But otherwise, I cannot think how we should have thought about it earlier. And that's what often happens in these cases with HIV. On tissue is the issue, as it was here. And yeah, thank you so much for it, Mario. This will definitely trigger a lot of reading, and I'm definitely gonna read about past staining. And yeah, thank you so much, Mario, for bringing this amazing case.
Okay, Ibrahim, take us home with the teaching points.
Okay, that was a great case. So thank you all so much for bringing on this wonderful case and amazing discussion tonight or today, whatever you are right now. So for the patient, we initially discussed their dysphagia, their weight loss, as well as their diarrhea. For this patient specifically, when we started talking about dysphagia, we were trying to differentiate between esophageal versus oropharyngeal dysphagia. And we were also considering a motility disorder, such as achalasia, before hearing what happened onto the HPI of this patient. And then for the weight loss, you need to consider whether this weight loss is unintentional versus intentional. And typically, you also need to consider whether this weight loss is significant enough or not medically. So if it was 5% from baseline in 3 months or 10% in 6 months, you would consider it significant enough. And then for the diarrhea, we started considering HIV with Candida. And for HIV with Candida specifically, after hearing on the oral thrush, you need to think about the immunological status of a patient who is presenting with oral thrush to your clinic first. And then also, when it comes to the immunological status, it doesn't always mean that they're immunocompromised or have HIV. Maybe they're on a medication such as steroids that is actually further causing them to be immunocompromised at the moment. And then for HIV specifically, oral thrush should not clue you directly to HIV. However, esophageal candidiasis, However, esophageal candidiasis should clue you into HIV because it's an HIV defining illness. And then also for the diarrhea, we considered IBD as well as Chagas, although this presentation would be a little bit atypical for Chagas since it usually presents with constipation. And then for the night sweats and fever, we started considering inflammatory versus infections versus lymphoma. For inflammatory, you need to think about autoimmune causes, such as dermatomyositis with GI manifestations. You also need to think about Sjogren syndrome, but in Sjogren, you need to look for the dry eyes and the dry mouth that are typical of Sjogren. And then you could also think about inclusion body myositis, but this would typically present with muscular involvement. For infections that are presenting with night sweats and fever, you can think of brucellosis and Bartonella based on the patient's epidemiological factors, especially considering that they were living in Peru. You could think about TB as well, CMV, HSV, and then as well as HIV, of course. And finally, you could think about lymphoma related to their night sweats and fever. We also discussed how H. pylori that this patient had could present with complications that could result in their presentation right now, including gastric cancer as well as carcinoid syndrome. And then when we heard more about this patient's physical, we found out that they had local lymphadenopathy. And if a patient presents with local lymphadenopathy, you need to think about exposure. So if they were exposed to rabbits, for example, you can start thinking about tularemia. You can also think about syphilis. And then if a patient presents with local lymphadenopathy, you need to carefully examine them just to make sure that they don't have other lymphadenopathy that maybe you did not uncover yet. And then we later heard that this patient had the diagnosis of HIV. If a patient has HIV and they're presenting to you for the first time with diarrhea, you need to think about opportunistic infections, including Candida, MAC complex, as well as TB, Cryptosporidium, Isospora, Histoplasma, as well as CMV. You could also think about HIV-associated diarrhea. And you also need to think about STD co-infection that they had with HIV. You could also think about acute HIV infection. So maybe this is just a presentation without an underlying etiology. You could think about IBD, IBS, as well as small intestinal bacterial overgrowth. And finally, you could think about lymphoma versus Kaposi sarcoma as well. And then we heard that this patient had anemia, so you would typically order an iron panel first thing, just to make sure that this is not due to iron deficiency anemia. And then upon hearing that this patient had low albumin, before you actually go into what might using their low albumin, you need to order or calculate for gamma gap, where you would look into the difference between the total protein and the albumin. And if you find that that gap is high, it means that there is added gamma globulins in between. And so this would be typical of polyclonal gammopathy. And then for the causes for low albumin that would typically go with this patient's presentation, we started thinking more about protein losing enteropathy. And then we heard that this patient had ulcers. So in ulcers, you have to differentiate specifically in HIV patients, whether this is HSV versus CMV ulcers. HSV would typically present with linear ulceration, whereas the CMV would typically present with punched out ulcers. And then finally, we discussed the periodic acid shift or the PS positivity. This is usually positive in fungal infections, including histoplasma, Whipple's, as well as Cryptosporidium, but it can also be positive in adenocarcinoma, as well as in Ewing sarcoma, as well as in erythroleukemia. And so finally, this patient had histoplasmosis of the esophagus, which we mentioned within our TPs. So thank you all for this session.
Wow, what a masterclass of teaching. Thank you so much, Ibrahim. It's like reading a book after that. So thank you so much. Thank you all guys for joining us. Thank you, Mario. And we hope you all have a great rest of your day and see you next time. Bye.